our attending physicians in the Division of Infectious Diseases here at Children's National. And Dr. Harik actually has been playing a lead role in helping us sort of identify and manage this child with measles, and will be our presenter today. Donita, if you can do two things. One, start recording, and two, let's shift the presenter rights to Dr. Harik so that we can get started.
Great. Thank you guys all so much. Thank you, Dr. Weissman, for inviting me to give this talk.
Just hang on 1 second, Nada, till we get your slides up.
Okay.
Or you're going to have to share your monitor.
Dr. Harik?
Yes.
Yes, Dr. Harik, you're going to have to share your screen now.
Okay, I've got it. I can do it though, right?
There you go.
Bingo.
Okay.
You are there.
Yeah, I'm learning.
Technology,
exactly. I'm a little bit behind in the technology, but I'm learning. Okay, all right. Thank you guys all so much. Again, thank you for inviting me to give this talk. Just a quick refresher on measles for everyone out there in our community. Let's start with our learning objectives. So today I really wanted to go over the clinical presentation and complications of measles, describe the epidemiology of measles in the U.S. and around the world, and also help you all to appreciate, which I know I'm preaching to the choir here, but the importance of vaccination and infection control measures in limiting the spread of measles. And I'd like to start today by talking about our local case that we have just had that I'm sure all of you have heard about and hopefully gotten alerts from either the Maryland or D.C. Or both departments of health about this case in particular. So this is a 2-year-old boy who recently emigrated from Afghanistan, and he developed fever 8 days after exposure to a child with measles that had occurred before he left Afghanistan. I want to review his illness course with you here in detail because it's going to be quite relevant when we talk about the clinical features of measles in just a minute. So just kind of keep this timeline in the back of your mind when we talk about the typical timeline of measles and what we need to worry about in terms of the length of time these individuals are considered contagious, and the overall incubation period for measles as well. So this child's illness started on day 1 with fever and no other symptoms. On day 2, he developed a runny nose as well as vomiting and was unable to really eat or drink very much. So he was taken to a local emergency department where he was kept overnight, so from day 2 to day 3. He was discharged home, and on day 3, additional symptoms began, which included cough. His parents described red eyes that began that day, and also some oral ulcers. These were described by his mother to his father as being white ulcers that she saw inside his mouth that were on the gums of both his upper and bottom teeth, just in the front of his mouth, nothing that they saw in his cheeks or further back inside his mouth. On the 4th day of his illness, his runny nose completely resolved, and he was taken back to the local emergency department for evaluation. On the 5th day of illness, back at home, his emesis had also resolved, but his other symptoms had continued, and he was taken back to the local emergency department for evaluation because his parents were concerned because he really wasn't eating or drinking even though his emesis had resolved. While in the local emergency department, he actually developed a rash that his father stated he saw there that involved his trunk, mainly his groin, and then also was just on one of his cheeks as well. It was non-itchy. It didn't seem to be bothering him. He did stay in the local emergency department overnight, and because of issues with dehydration and just evaluation for possible other etiologies of his illness like Kawasaki, he was transferred to Children's National the next day as a direct admission for further care. So on his day of transfer, shortly after arriving at the hospital, we actually obtained his history of the measles exposure. It hadn't been obtained prior to that time, and I really want to thank Dr. Stephanie Todd, an astute physician who picked up on that exposure history, which really was the key to making the diagnosis in this particular child. So I can't stress that enough, how essential that was for us making the diagnosis. At that time, his fever had resolved, and he actually remained afebrile during his entire hospitalization at Children's National. We were contacted from the Infectious Diseases Service at that time, and I'll talk a little bit more about our role on the next slide and what we did as well. On the 7th day of illness, his rash was really resolving, involved only his groin, and his conjunctivitis had resolved. His only other remaining symptom was a mild intermittent dry cough. On the 8th day of illness, he was judged to be eating and drinking well enough to maintain his hydration, and he was discharged home. We did give him instructions that he should remain at home and not go out into the public until 4 days after his rash had resolved, because at that time, obviously, measles was on our differential diagnosis. Now, while there certainly were a lot of findings and things in his illness course that were concerning for measles, there were also some things in his history and illness course that made it a little bit less likely. And again, it really was his exposure history that I think was the key for us in thinking about measles and making the diagnosis. So shortly after he was admitted to the hospital, he was placed on airborne isolation, where he remained throughout his hospitalization. We did obtain measles IgM and IgG, and we obtained specimens for PCR testing to send to the health department if needed. But after seeing how well the child was doing, how quickly he'd effervesced and his rash was resolving, and obtaining a history from the child's father and seeing documentation that he'd had 2 doses of MMR vaccine, we elected to hold off on sending the specimens for PCR, but still treated the child and considered him as a very likely case of measles. Subsequently, his IgM returned positive and his IgG returned negative, and his nasopharyngeal specimen, which had been collected during his hospitalization, was sent to the Maryland Department of Health, where it was PCR positive. So that's how his diagnosis of measles was made. So I really want to say there that really the key for this particular case was to take a complete travel and exposure history. That was what brought us to diagnosis in this child's case. So let's talk a little bit about typical clinical features for measles. So the incubation period is 7 to 21 days after the exposure, and symptoms typically begin between 8 and 12 days after their exposure. If you recall, for our case, the symptoms began 8 days after he had been exposed to a child that had measles, and so that is particularly why we were concerned about it in this case. The average interval between the appearance of the rash in an index case, when we're talking about family members, and subsequent cases in the same family, is 14 days. So measles, as you all know, is an acute viral respiratory illness. There's a 2 to 4 day prodrome of fever, malaise, cough, coryza, and conjunctivitis. And then we can get that pathognomonic enanthem, which is the Koplik spots. I'm going to show you some pictures about that later so you'll recognize them. Those typically appear about 48 hours prior to the exanthem. These are about 1 to 3 millimeter, whitish, grayish, or bluish elevations that tend to have an erythematous base, and they're typically seen on the buccal mucosa opposite the molar teeth, although they can spread to cover other areas of the mouth, including the hard and the soft palate. And they typically tend to slough and disappear when the exanthem appears. When we saw this patient, he had no oral ulcers, no lesions in the mouth whatsoever. And then the exanthem, which typically appears 2 to 4 days after the onset of the fever, is an erythematous maculopapular blanching rash, which classically begins on the face and then spreads to involve the neck, the trunk, and the extremities. Clinical improvement in the child's symptoms usually ensues about 48 hours after the appearance of the rash, and then the rash often lasts 6 to 7 days, and it fades in the order that it first appeared. That's kind of our classic measles. So not necessarily exactly what we saw in our patient, but classic measles. And then here are some pictures. So you can see here a 6-year-old girl with the early facial rash and conjunctivitis that we see with measles, and then another child with the classic red blotchy rash on his face and body. This was the 3rd day of his rash. And then I've got some other great slides here. Thank you very much to Dr. Roberta DiBiase, who sent me her slides from a previous talk that she had given on measles. So you can see here the many faces of the rash, conjunctivitis, and coryza that we see with measles. Remember, we have those 3 C's, so cough, conjunctivitis, and coryza. And then a few more pictures of the classic rash that we see with measles as well, the morbilliform rash. Differential diagnosis for measles can include other things like scarlet fever, Kawasaki disease, Rocky Mountain spotted fever, and dengue. And I love this old slide from a plate that just compared the rash of measles with the rash of scarlet fever. And then just some photos for you to see the complex spots. There you can notice the characteristic white lesion with the erythematous margin. And these were 2 pictures that are from the Red Book Online, which is a wonderful atlas. Okay, let's show a quick video here. This is from the CDC describing clinical features of measles.
So I just,
After an incubation period of 10 to 12 days, there was a stepwise increase in temperature, 103 degrees Fahrenheit or higher. What usually follows is classified cough, coryza, runny nose, and conjunctivitis or pink eye. An astute observer may see complex spots, a rash found on mucous membranes, a day or 2 before the cutaneous rash. This prodrome usually lasts 2 to 4 days. The rash appears about 14 days after exposure. It is caused by deposits of measles antibody in the skin. Rash papular appears first on the face. During the next 2 or 3 days, it descends to the trunk, then to the arms and legs. The rash fades in the order of appearance. You may have seen measles when it was more common in the late 1980s and early 1990s. For those of you who have not seen it, here's a visual aid.
This is a child with measles prodrome. Measles prodrome usually produces a moderate illness. Notice the coryza or runny nose and her red, teary eyes indicative of conjunctivitis. This is measles at about 2 days into the rash or 5 to 6 days into the illness. The rash is maculopapular and demonstrates coalescence when the discrete macules bind into larger red skin lesions. Cough is almost universal with measles. The rash is typically most intense on the head and upper chest, but is usually present on the lower chest and arms. This is a dark-skinned child with measles. The child has conjunctivitis and coryza. The rash is papular or raised, not flat. A measles rash is more difficult to see with dark skin. If the rash is accompanied by other symptoms, such as cough or conjunctivitis, measles is easier to diagnose.
If you see or hear about a person who had an influenza-like prodrome of cough, coryza, and fever, then developed a rash, you should suspect measles. You should be really suspicious of that person unvaccinated or has a history of recent international travel. If you suspect that someone has measles, you should obtain a blood sample for serology and a nasopharyngeal specimen for viral isolation. Notify the state health department as soon as possible. Do not wait until lab tests come back. Control measures must be started immediately, not later.
Okay, so I'm going to pause there, and that was a nice video, I thought, a wonderful video of a child with measles for those of us who've actually not seen clinical measles before. So I want to take a second here to actually talk about atypical measles syndrome, which is a little bit more similar to how our particular patient developed. This is something that was first described in the mid-1960s. And was seen after the advent of measles vaccination, and was often how measles presented when there were breakthrough cases in individuals who had been immunized. Teenagers and young adults were affected most commonly with atypical measles syndrome, and there was prominent pulmonary involvement. They often had a infiltrate on a chest x-ray, and some individuals could also have a pleural effusion. Typically what was seen is the high fever, cough, and coryza, but many times there was also high fever with only cough, and coryza and conjunctivitis were absent. In general, the clinical symptomatology is much milder with atypical measles syndrome than it was with the classic measles description that I showed you earlier. However, the classic description is very important for all of us to keep in mind because it is what we would typically expect to see, for example, in an unimmunized individual. The rash with atypical measles syndrome can be different. It can present as a vesicular rash. It could be predominantly petechia with some purpura. This is where there's often a lot of confusion about a rickettsial illness such as Rocky Mountain spotted fever. Or it can be an erythematous maculopapular rash that mainly has prominence on the trunk and the groin, similar to what we saw in our patient, and this rash is often described as being very similar to scarlet fever. These individuals typically had a low white blood cell count as well with a left shift and often had issues with headache, myalgia, malaise, and not wanting to eat, anorexia. All right, so measles itself, as we all know, can be serious. About 1 in 4 people who get measles will be hospitalized, and about 1 in every 1,000 people who have measles will develop encephalitis. Of those individuals, 25% of the children will have neurodevelopmental sequelae. 1 or 2 in every 1,000 people who get measles will die. And then I think we all have heard about subacute sclerosing panencephalitis, or SSPE. Its pathogenesis is not well understood, but there may involve some persistent infection with the measles virus within the central nervous system. This is a fatal, progressive, degenerate CNS disease. It usually occurs 7 to 10 years after measles virus infection. It is more common after infection with the wild-type measles virus, but occasionally can be seen very rarely after vaccination as well. All right, so very quickly, I'm not going to spend too much time on the diagnosis of measles, other than to say that serology is helpful in individuals who have not been immunized especially, and that would be to get a serum measles IgM antibody as well as measles IgG. We often want to look at paired acute and convalescent specimens for IgG that are collected at least 10 days apart to look for a significant rise in IgG to make the diagnosis of measles. And then most helpful in today's day and age are often measles RT-PCR studies. They can actually be sent from a throat or a nasopharyngeal specimen. They can also be sent by urine. Those need to be sent to your local Department of Health or directly to the CDC if you're concerned about measles. You can also obtain throat, nasopharyngeal, or urine samples for viral culture. I just put a link there for the CDC website that talks about the appropriate testing that we're going to get for measles. The detection of measles RNA tends to be most successful when we get it early in the illness. So the biggest yield is in the first day of the rash through the 3 days following the onset of the rash, although it can be positive as late as 14 days after the rash onset. The anti-measles IgM is usually detectable about 3 days after the onset of the rash, but can even be undetectable by the time the rash appears. And usually fades away and is undetectable at about 30 days after the rash has first appeared. Okay, so I really want to say the important point there is to think about measles. You've seen the typical measles symptoms, and if you see those symptoms in a child, definitely be sure to include measles on your differential diagnosis, and that's because measles is still here. So as you all know, before live measles vaccine was licensed in 1963, every year in the United States, we had huge numbers of people infected with measles, 3 to 4 million people. And of those reported cases, every year, about 1 in 10 people were hospitalized, 1 in 100 had encephalitis, and 1,000 people each year developed chronic disability from acute encephalitis. There were also about 1 to 3 deaths per 1,000 individuals when measles was endemic in the United States. However, since the year 2000, measles has no longer been considered endemic here in the U.S. However, worldwide, it is still considered endemic in many, many areas. In the pre-vaccine era, there were 2.6 million deaths per year worldwide due to measles. And in 2015, there were still 134,000 measles deaths over the entire population of our Earth, with about 15 deaths occurring every hour, according to the World Health Organization, due to measles. So let's talk a little bit about measles resurgence. It was initially declared eliminated and non-endemic in the United States in 2000, but since then there's been a rising number of cases in our country, and we all want to know why. Well, that often has to do with declining immunization rates, especially certain little pockets where immunization rates can be very low. We also have increased travel, so we're traveling all over the globe, especially to areas where measles can still be endemic or there can be an epidemic of measles. And some countries that had previously no longer been endemic had the return of endemic measles. In particular, I want to point out measles, so in the UK. So in the UK, measles was considered eliminated and no longer endemic in 1994. But as we know, in 1998, there were claims that the MMR vaccine caused autism, and that resulted in a huge drop in immunization rates with MMR in the UK. The rates became low enough by 2008 that measles was reported to be endemic again in the UK at that time. And right now, there are 14 countries in Europe where measles remains endemic. So measles can very easily enter our country from visitors traveling to common destinations like England, France, and Germany, and also to more exotic places, but not quite exotic to us here in D.C., like Africa and especially Asia and the Pacific. I highlighted the Philippines there because we're going to talk about the Philippines as being a strain that was a source of quite a few measles outbreaks here in the United States. So you guys all know about the 2015 multi-state measles outbreak that started a traveler who likely became infected overseas with measles and then visited a certain park in California while infectious, but the actual source case was never identified. The cases led to 52 outbreak-associated cases of measles, and they were in multiple states, as you can see in the map there. The measles virus in that outbreak was determined to be type B3, and that was identical to a type that had caused a large measles outbreak in the Philippines in 2014, and actually had even caused a larger outbreak in the United States in 2014. So here you can see the number of U.S. measles cases per year from 2010 till 2016. I don't have the graph for 2017 yet, but I'll tell you a little bit about that data. But you can see actually the biggest outbreak was in 2014 when we had 667 cases reported in the United States. There was one large outbreak of over 380 cases that occurred among unvaccinated Amish communities in Ohio, and most of those cases were again associated with a strain that was felt to be imported from the Philippines. In 2016, you can see the complete numbers there. We had 70 cases of measles in 16 different states. And then so far in 2017, as of April 22nd, there have been 61 cases reported in the United States. You guys all know about the most recent outbreak that were noted, which is in Minnesota. Right now there are 69 cases total that have been reported in Minnesota. Of those, 65 of the children have been confirmed to be unvaccinated. One had 1 dose of MMR and 3 had 2 doses of MMR. 66 of the cases are in children less than 17 years of age. 3 cases are in adults. And the vast majority of these are in the Somali Minnesotan community. I'm going to show you an interesting graph here. This was actually information from the Department of Health, but this was published in the Washington Post that showed that in the early 2000s, the Somali Minnesotan, Somali American population actually had very great rates of immunization for MMR, higher than the non-Somali population in Minnesota, 92%. But subsequently, the rate dropped off there was a concern in that community about the measles, mumps, and rubella vaccine. Individuals took advantage of that concern, and the measles, mumps, and rubella vaccination rate dropped significantly. So in 2014, it was only 42% in the Somali Minnesotan group, and then you can see the large outbreak that we're having now due to that. Okay, so our important point there is to just really be thinking about measles, and then I just wanted to show this map. This is pretty recent cases as well between February 2016 and January 2017, showing outbreaks of cases in many areas in Europe, and as you can see, there was over 1,000 cases in Italy. Again, these are locations where many of the kids that we see travel to routinely. All right, so let's take a little break and talk about measles vaccine efficacy. You guys know the available preparations of measles vaccine. There's the MMR, which is approved for children greater than 12 months of age, and then there's the MMR-V combination vaccine, which is measles, mumps, rubella, and varicella. That's approved for individuals 12 months through 12 years of age. There is not a single antigen measles vaccine available. One dose of MMR vaccine is considered 93% effective at preventing measles. The vaccine failure rate has been reported to be between 5 to 7% in those who receive a single dose. And actually, specifically to address primary vaccine failure, that's why we give the second dose of MMR. When we give 2 doses of MMR, it is really considered to be 97% effective when the second dose is given at least 28 days after the first dose. However, there are still some individuals who can develop measles after having a second dose of MMR. And in our particular case, with our patient, the concerns were also because he had received his MMR vaccine in a different country. We really can't speak to processing and the whole chain of vaccine in different countries. So I'm sorry. Can you guys
sorry, folks. There's some background noise, so.
Let me get you.
I'm pretty easily distracted, so sorry. I'm good.
So we should be good if I bring these back.
Okay. So again, I think the concern that we have right now in our particular case is there may have been a failure in the cold chain with that vaccine. But please keep in mind the vaccine is extremely effective, although we can't speak as much to vaccine that's given in other countries besides the United States. Again, we talked about almost everyone who doesn't respond to the measles component of the first dose of MMR will respond to the second dose. Okay. So what is the evidence of presumptive immunity to measles that we go by and certainly that we're concerned about when we have a case spreading in the community? And that is that we have written documentation of adequate vaccination. So that's 1 or more dose of a measles-containing vaccine administered on or after the first birthday for preschool-aged children and also for adults that are not considered at high risk. That does not apply to healthcare workers. We are considered at high risk. And then 2 doses of measles-containing vaccine for school-age children and then adults who are high risk. Those are considered children who are in high school and beyond, healthcare personnel, and international travelers. And just please a reminder that international travelers that are 6 months through 11 months of age should get a dose of MMR vaccine prior to travel. I think sometimes that's something we tend to forget, and a lot of times it's because we don't know people are traveling. But if we know and we ask about it, then we definitely want to get those children immunized because, as you can see, the high rates of measles that are still out there in other countries. If you have laboratory evidence of immunity with serology, you're considered presumptively immune. If you have laboratory confirmation that you had measles, and if you are born in the United States before 1957, you are considered immune, but that does not apply to healthcare workers. That has been removed because there have been breakthrough cases in healthcare workers who were born before 1957. So let's talk quickly about herd immunity. I'm going to skip what it is because I think what you guys know that already. But overall, luckily, national vaccination rates against measles have been very stable since the Vaccines for Children program was introduced in 1994. And then here's some data from the CDC, just giving you overall national coverage for MMR vaccine among children 19 to 35 months of age. That was 94% in 2015, but that range is highly variable by state. So the range is anywhere from about 87% to 99%, depending on which state you live in. And you have to remember that at county levels or even lower levels in neighborhoods, vaccine rates can really vary considerably, and there are these pockets of unvaccinated people that exist even in states that have very high vaccine coverage. We particularly see that in areas like California and on the West Coast, but we can even see that locally. So really quickly, this is another map from the CDC. This is looking at kids that are to enter school, so school vaccination assessment report, and you can see the percentage of children that have had appropriate vaccination. And it's hard to see DC on this map because it just gets swallowed up between Maryland and Virginia, but the numbers actually for DC are 88.5% of our kids enrolled in kindergarten are appropriately vaccinated. In Maryland, it's 99%, and in Virginia, it's 96%. And then just looking at coverage rates for measles, mumps, and rubella among adolescents. This is data from kids 13 to 17 by state. Again, you can see the map there with the generalized figure. And again, the lighter colors on the map are rates where immunization numbers are lower. But the numbers here for us locally are DC 90%, Maryland 94%, and then Virginia 87%. And I do want to just comment that to really disrupt broad transmission, herd immunity is supposed to be maintained between about 85 to 95% for us to disrupt broad transmission in the community. So our next important point is help us fight against measles. Our most powerful defense is actually immunization. All right. I want to leave some time for questions, so I'm going to try to go through the rest of this pretty quickly. We all know measles is very contagious. 9 out of 10 susceptible individuals who have close contact to a patient with measles will develop measles. It's one of the most highly communicable of all infectious diseases. We dread it in infectious diseases, and infection control is for that reason in particular. It's transmitted by direct contact with infectious droplets or by airborne spread when an infected person breathes or coughs or sneezes. And here's the thing that really gets us about measles virus. It can remain suspended in the air for 2 hours. So if a kid with measles gets on an elevator and sneezes, and then you get in that elevator an hour and a half later, the measles virus can still be in the air on that elevator. Remember, again, patients are contagious from 4 days before the rash till 4 days after the appearance of the rash. We did tell our child that they had to be secluded for 4 days after the appearance of the rash, and the family was very compliant with that, and there was no risk for further spread after this child left the hospital because of that. We want to use airborne precautions before we examine a patient with possible measles. I'm going to tell you what we want to do here just kind of for our office practice immediately, but generally we want to try to take a patient that we think might have measles, so a febrile rash illness, escort them to a separate waiting area or place them in a private room, preferably place them in a negative pressure room as soon as possible. If that child does not need to be admitted to the hospital, again, they should be told to remain in isolation at home through the 4th day after the rash onset. So when we're talking about measles control measures, the first thing we want to do is define exposure. So we want to look at individuals that don't have proof of immunity. We want to know about individuals who are in a space that shared the same air handler system or the index measles case were. And then we have to remember that that exposure duration includes 2 hours after the index case leaves the space. And then for care of exposed susceptible individuals, MMR vaccine is very helpful if we give it within 72 hours after the exposure, or if we give immunoglobulin within 6 days after the exposure. Typically, we only recommend immunoglobulin either for pregnant women that don't have evidence of measles immunity or for severely immunocompromised hosts. It's not recommended for even household individuals or close contacts that they've received a dose of the vaccine at 12 months or older. Again, it's mainly for severely immunocompromised individuals or for pregnant women that don't have evidence of measles immunity. And then healthcare personnel who are considered susceptible to measles need to be excluded from duty from their 5th day to their 21st day after their last exposure, and that's regardless of whether they're given the vaccine to get them updated or they're given immunoglobulin. They still need to be excluded from work. And then please recall for healthcare workers that age criteria for being born before 1956 is not applicable in terms of giving evidence of immunity. So for all possible cases that come to you, what we want you to do is to immediately place the patient in a negative pressure room if it's available. If that's not available, put them in a room with a closed door. Place a standard isolation mask immediately on the patient, and then a N95 mask or a PAPR should be worn by an immune healthcare provider when interacting with the patient. We want you to notify infection control and infectious diseases either at your facility or you can notify us for help, and then immediately notify the local Department of Health as well. Remember, only healthcare providers that have evidence of immunity can enter the room, and if you're not sure about your immune status, check with your occupational health team or with your physician to determine if you are immune. So just an important point, again, airborne precautions is what we want to do to prevent transmission. Overall, what can we do? I think this is really important. We can be vaccine advocates. We need to ensure that all our patients are up to date on their MMR vaccine. We need to ensure that everyone in our healthcare facilities and our clinics is also up to date on their MMR vaccination. We need to screen at office entry for a fever and rash-like illness and isolate suspected measles case patients immediately in the way we just talked about. That's especially important right now in this period that we have of exposure, since we did have a single case here in our area. And just as a reminder, it's 21 days after exposure to that case, and our last day that we're worried about with this particular case of exposure to anyone in the DC or Maryland area is going to be June 3rd. So June 3rd is our potential last day of exposure that we're concerned about. Remember to please consider measles as a diagnosis in anyone who has a febrile rash illness and has clinically compatible symptoms, especially if they've had recent travel abroad, and especially, like in our case, if they've had contact with somebody who's had measles. Again, our case was not classic in terms of all of the symptoms. And his rash was not what we would describe as the very classic measles rash. But we were very lucky with our astute hospitalists, like I mentioned earlier, who got that exposure history, and with our timeline falling into place with development of symptoms after the exposure, we really were concerned this could be measles. And then remember, please to immediately contact your local health department to report cases and to obtain assistance with submitting specimens for testing or with any questions you have, or please feel free to call the Infectious Diseases Division as well. And then I've got some resources on the slide because I'm hoping these slides will be available to you even after this talk. Okay, so I'd like to end there and just leave it open, I guess, for questions or comments.
First, Nada, yeah. Nada, can you hear me?
I sure can.
Great. Okay, the phones are muted, but we're going to open them in a sec. I want to thank you for a great presentation. I guess I want to remind the folks who have sort of logged in. We did a measles presentation a couple of years ago. Part of the reason we did this again is that there is a new case in the community, and you know, sometimes it's an isolated case, but given the contagiousness of this virus, we're sort of entering this window now where there may be secondary cases. The child was out in the community during a period where he may have been infectious, and we wanted to get it on the radar screen of our community pediatricians and also reminded them just to include this in the differential.
Absolutely, and Mark, sorry, I meant to mention during the earlier in the talk that please refer to the reports from the DC Department of Health and the Maryland Department of Health that give you the timeline of activity for this patient. that will help you if a patient comes in and you're concerned that may have been exposed. And I have the link here in the resources specifically to the DC Department of Health letter, and that describes the areas in particular where we worried there may be exposure that was with this particular patient.
I'm not seeing any questions that have been chatted in. We are going to attempt to unmute the lines and see what happens. Sometimes there's a wall of background noise and we have to quiet things down, but if there are any questions, we're going to try unmuting the phones now, Danita, and see what happens.
So, Dr. Weissman, there is one question in the chat box. It's from Dr. Patter. Is there data to suggest that MMRV given at 12 months of age is less effective than MMR alone?
So that's a good question, and there is no data to support that.
Okay. So I will unmute everybody now.
Let me see if there's anything on the side. Yeah, I have a fan here. Do you want the fan?
Okay. Are there any questions from our folks sort of dialed?
And I think Dr. DiBiase's on the line too, so I don't know if she has any comments or other teaching points as well.
That's the big one. Okay. Oh, just how do you not bite you? Man.
Can you hear me?
We can.
Okay. Well, from what?
We're going to quiet things. There's just too much noise to do it that way. Thanks, Danita. So if folks have any questions, please use the chat box. I do want to thank Dr. Harik for really getting a lot of comprehensive information in a tight lunchtime time for our busy practitioners.
Everybody eyes. Where are they getting them ready?
They look red. They look good, but they look fine right now. You can try. 1, 2, 3, tickle.
And actually, Danita, can you make me the presenter again?
Okay.
Ready? 1, 2, 3. 1.
I'm here. Let me put a Band-Aid. What happened to you?
Looks like we're live practice with someone getting their car.
So why didn't you rinse your mouth?
Good. I'm going to
Put the Band-Aid down and rinse. Put the eyes down and rinse your mouth.
You know what?
Dr. Weissman, your presenter.
Because you didn't want us to do that very. What if we had to look for your ears?
I'm not seeing a screen share here.
Marcette, do you have a result? Yeah, I figured it would be. So we'll send the code out. I mean, I don't, like they said, the only thing I'm seeing is enlarged tonsils, but I don't have a baseline on him. I mean, when he goes to the pediatrician, the pediatrician always says, tonsils are so big. So, okay. My heart is when we go to the pediatrician.
So what happened to him?
Yeah. And again, you can get enlarged tonsils because of the virus on the ear. They don't look like they look red or they're just
Muted.
So thanks, everybody. I think what we're going to do is we are going to wind down today's presentation. We are able to offer CME credit, and so the two ways to get CME credit for today's presentation are, one, if you logged in clearly with your name and email address, we will give you the credit automatically. If not, you'll need to forward that information to Danita Pickett at dpickett, P-I-C-K-E-T-T, at childrensnational.org. If you do that, we'll be able to send you an email connecting you to email credit. Yeah, if you sign in with your initials only, that won't be good enough. We are recording this session and hope to have this posted online so that if you have colleagues or others who are interested in viewing this and getting an update, that'd be great. We are in this window where we may start seeing secondary cases in our community, and we wanted to at least try to get the information out to practitioners both within Children's National and around the metro area so that everyone's on alert. So thanks so much for Dr. Harik for a great overview and presentation. And thank you all for listening in. We hope to see many of you at our Future Pediatric CME program on Tuesday and Wednesday, June 20 and June 21st at the Bethesda Marriott. So thanks so much.